Hello, good afternoon, everyone. Just want to make sure we're on 262 pre-operative evaluation of thyroid cancer, including the importance of having an accurate ultrasound before surgery and cross-sectional imaging in patients with aggressive thyroid cancer or bulky lymphadenopathy. So we do have Dr. Sara Ahmadi, which you can see in the visual screen. And just to tell something about Dr. Ahmadi, um, she's an associate physician in the Division of Endocrinology, Diabetes, and Hypertension at Brigham and Women's Hospital, Harvard Medical School in Cambridge, Massachusetts. Her area of excellence is clinical expertise in thyroid disease, with her remaining time devoted to teaching, clinical research, and peer review. Previously, she was an assistant professor of medicine at Duke University in Durham, North Carolina, and a member of the Duke Endocrine Neoplasia team and the Duke Cancer Institute from 2016 to 2019. Her main area of interest research is thyroid nodules and thyroid cancer, and she has worked on different research projects with the BWH thyroid team since joining BWH HMS in September 2019. She has served on several committees and task force of the American Thyroid Association and Endocrine Society. It's been a pleasure to have Dr. Sara Ahmadi to give this very powerful talk. At the same time, thank you for coming today. This is your moderator, Nancy. So let me transfer you, Dr. Sara Ahmadi.
Thank you so much for the kind introduction, and it is my pleasure to be here. I have no conflict of interest. These are the objectives, the outlines of my talk. I'm going to first start with what are the risk factors for malignancy in a patient who is diagnosed with thyroid nodule. And then we will cover the imaging that should be done before thyroid surgery. And after that, we will discuss the recommended blood work before thyroid surgery. And then at the end, we will discuss about patients' preferences when about thyroid surgery. I will start with a case. A 50-year-old female who has been recently diagnosed with breast cancer is referred to endocrine clinic after she was found to have an FDG-avid thyroid nodule. It is not uncommon that patients with other malignancy, they have a PET-CT, and they are incidentally found to have a nodule, and they're being referred to endocrine clinic. This patient has no symptoms, including difficulty swallowing or hoarseness. During physical exam, the patient's blood pressure is normal, the patient pulse rate is normal, but the patient has a 2 centimeters palpable thyroid nodule that moves with swallowing. There is no palpable cervical lymphadenopathy, and the rest of the physical exam is normal. Now, why am I presenting this case? Because every patient that is diagnosed with thyroid cancer, they initially presented to the endocrine clinic or to the surgery clinic with a diagnosis of thyroid nodule. When patients with thyroid nodule come to endocrine clinic, there are a few questions that every endocrinologist asks the patients because they're trying to risk stratify the patient and understand what are these patients' risk factor for thyroid cancer. One of the questions that every endocrinologist would ask the patients is about about the history of radiation during childhood. This has been studied very well. We know that patients who had radiation during childhood, they will be at higher risk of malignancy, thyroid malignancy. Also, the other question every physician would ask the patient is about the family history. They're looking for familial thyroid carcinoma. There are some syndromes that would increase the risk of thyroid malignancy. One of them is Cowden syndrome. The other one is familial adenomatous polyposis, and also patients with multiple endocrine neoplasia. And so it is not uncommon for endocrinologists to ask these 2 questions as the first 2 questions during the history when they see a patient with thyroid nodule. But also if the patient already had other imaging like a PET-CT and the nodule light up in the PET-CT, that could by itself increases the risk of malignancy. Studies have shown that if the patient has FDG-avid nodule, that has around 39% risk of malignancy. After the history and physical exam, the first test that every endocrinologist would order to decide on the next step for a management of patient with thyroid nodule is ultrasound. Ultrasound would help us to risk stratify thyroid nodules. We actually use the ultrasound features of a nodule to predict the risk of malignancy. This is the current ATA guidelines, which was published in 2015. This is going to change. I mean, this is going to be modified in the recent guidelines. It's going to be published hopefully this year. But when we look at the ultrasound, if the nodule is completely cystic, we should reassure the patient that you're fine because the cystic nodules are benign. But then based on the ultrasound features, we can also classify nodules to 4 different groups: very low suspicious, intermediate, and high suspicious. Very low suspicious have a really low risk of malignancy, less than 3%. Low suspicious, around 5 to 10%. Intermediate, 10 to 20%. And high suspicious, more than 70 to 90%. Based on this, we will decide who should have a biopsy, because we don't necessarily biopsy every single thyroid nodules we find. Thyroid nodules are very common. Almost 50% of people by age 60, they have a nodule in their thyroid gland, and it's more common in women. That's why we use technically those ultrasound features to decide who should have a biopsy and who doesn't need to have a biopsy. And also typically we don't biopsy nodules which are less than 1 centimeters unless the nodule is highly concerning for thyroid malignancy and it is close to a major structures or there are suspicious cervical lymph nodes. Besides that, there are also some other features in the ultrasound that could also raise the concern for thyroid malignancy besides what we just discussed. One of the papers that was published not too long ago, it showed that the shape of a thyroid nodule could be also a predictor of a thyroid malignancy. This was done by our team at the Brigham. We looked at around 4,282 patients. And around 2,201, they had 1 nodule, and around 2,081 patients had 2 nodules. And they found that if you look at the long to short ratio, in malignant nodules, it was around 1.6, and in benign nodules was around 1.7, and that was statistically significant. Again, that is something that the clinicians will, when they look at the ultrasound features of a nodule, they also look at the shape of a nodule. The shape of a nodule can also give them an idea what the risk of malignancy would be in this nodule. And interestingly, the risk of malignancy continuously increased as the long to short ratio approached to 1. For example, the nodules, if the ratio was more than 2, the risk of malignancy was around 14.6%. But if the ratio was 1.5 to 2, the risk was around 19.7%. And for the ratio 1 to 1.5, the risk was around 25.5%. And that was also statistically significant. In this study, also we found that besides the shape, the age, the male sex, and the nodule size more than 4 centimeters were also predictor of a thyroid malignancy. Now, one of the questions that has been raised in the recent years is that why the incidence of thyroid cancer has been increasing over the years. And one of the questions that has been raised by multiple papers has been the risk of the relationship between thyroid cancer and obesity. There are studies that have shown that there might be a relationship between thyroid malignancy and obesity, and there are also studies that have shown there is no relationship. There are also studies that have shown that there might be a relationship between thyroid malignancy and aggressiveness of thyroid cancer. These questions remain unanswered, because there are controversies. Some studies have shown that there could be a relationship, and some have shown that there is no relationship. There was a study that we did at the Brigham to answer these questions. We looked at around 1,259 patients, and around 199 patients had thyroid cancer, and around 1,060 did not have thyroid cancer. They had benign disease. Not surprisingly, majority of these patients in this cohort were female patients because thyroid disease is more common in female. And the mean BMI for patients who had thyroid cancer was around 28.9, and the mean BMI for patients who had benign disease was 28.6. And we did not find a relationship between the BMI and thyroid malignancy. We even looked at specifically on patients that they had a BMI below 18.5 and patients who had a BMI more than 35, and still we didn't find a relationship between obesity and thyroid cancer. Now, why did I discuss all of these things? Because I wanted just to give you a background that how actually thyroid cancer is diagnosed. I mean, any patients who come to the clinic, before they get diagnosed with thyroid cancer, they actually come with thyroid nodule. And this is how we start the process. We ask patients questions because we're trying to see if the patient has any risk factor. We order ultrasound, and based on that, we will decide who should have biopsy and who shouldn't have a biopsy. Now, this is our patient. This patient came with an FDG PET CT, didn't have an ultrasound. We ordered the ultrasound, and this is the ultrasound of this patient. This is the trachea. The thyroid gland looks like a butterfly, and this is the nodule that this patient has. Now, this patient was recommended to have a biopsy, and the biopsy came back positive for papillary thyroid cancer. The next step would be referring the patient to surgery. Now, the patient already had the biopsy confirmed the diagnosis. What other tests do we need to order in a patient who gets diagnosed with thyroid cancer? The first test that everybody orders is the ultrasound. But unfortunately, in many places, when they do ultrasound, they only look at the thyroid gland. It is extremely, extremely important that when the thyroid ultrasound is done, the lateral neck to be included. Why is that? Because if the patient is diagnosed with thyroid cancer, one of the first places that the thyroid cancer can spread is the lymph node in the neck. And we need to make sure that the lymph nodes, they don't look abnormal. Because if the only area that is scanned is the thyroid, and we don't know about the status of the lymph node, the patient goes to the operating room, the surgeon will only remove the thyroid gland, and then a few months later, after the surgery, we find out those abnormal lymph nodes were there. We didn't know about them because nobody scanned that area, and the patient has to go back for second surgery. Unfortunately, this is not an uncommon scenario because many places, they do not necessarily scan the lateral neck. That's why as a patient, it is extremely, extremely important that you ask this question that, did they scan my lateral neck? Did they look at the status of my lymph node before I go for surgery? Because you want to make sure all the disease is removed during the first surgery. You don't want to have a second surgery just because the lateral neck was not scanned. Now, another case, a 42-year-old female who was found to have a thyroid nodule. She has no family history of thyroid cancer and no personal history of radiation exposure to head and neck. She has no symptoms. She also had a biopsy, and the biopsy came back positive for thyroid malignancy. This is the patient's thyroid nodule. As you can see, it is very small. I did not include the size in this slide, but this nodule is less than 1 centimeter. This nodule is highly suspicious. And we typically don't biopsy a nodule, which is less than 1 centimeter, but this nodule needed to be biopsied for 2 reasons. Number 1, the nodule is very close to trachea. But number 2, when the ultrasound was done, the ultrasound tech did a very good job. They scanned the lateral neck as well, and they found this abnormal lymph node in the lateral neck. Technically, if the patient did not have a good ultrasound exam, this patient would have just found to have this small nodule, and somebody could have probably told the patient, well, your nodule is very small, we are going to just watch it, which would have not been the appropriate recommendation. Because even though this nodule is small, this nodule has a worrisome ultrasound features. It is very close to trachea, and because the complete exam was done, this lymph node was found, and this patient actually was found to have thyroid cancer with lymph node metastases. And because the complete exam was done, then the patient ended up having the appropriate surgery, which was a total thyroidectomy and lateral neck dissection. And the patient was found to have actually multifocal papillary thyroid cancer. It wasn't only the nodule that we saw in the ultrasound. And even though we didn't see 8 positive lymph nodes, but because when the patient had a lateral neck dissection, they found 8 out of 36 lymph nodes positive, and the largest lymph node was the one that we actually saw in the ultrasound pre-op. The second case is a 56-year-old male who has a positive family history of thyroid cancer in his brother. He sees his primary care physician. He's anxious because of the family history, and he requests to have a physical exam, and he is found to have a thyroid and also an ultrasound. He is found to have an thyroid nodule. He has a biopsy. The biopsy comes back positive. Now, unfortunately, this is a real story. this patient did not have a good ultrasound before he went for surgery. And he was told, okay, well, your nodule in the other side is very small. We're going to just do a partial thyroidectomy. And he had a partial thyroidectomy, and he was found to have multifocal papillary thyroid cancer. Now, he comes to our clinic. Yes, we agree. The nodule in the contralateral lobe is very small. This is the trachea. This is the remaining of a thyroid gland. And this is a tiny nodule. Nobody would biopsy this tiny nodule. But when we move the probe, we see that there's an abnormal lymph node in the lateral neck. This is not new. This was there to begin with. That is why it's extremely important that the lateral neck to be included when the ultrasound is done. This patient had a biopsy of this lymph node, which was there to begin with. Not surprisingly, the biopsy came back positive, and the patient ended up requiring a second surgery. And he had completion thyroidectomy, and he was found to have papillary thyroid cancer in the other lobe as well, and he was found to have 3 out of 23 lymph node positive. That is why it's extremely important the lateral neck to be included, because if this patient had a good ultrasound to begin with, all of the disease could have been removed during the first surgery, and he didn't need to go for a second surgery. Now, what is a lateral neck? Thyroid gland looks like a butterfly. It sits here in the lower part of the neck. We actually divide the neck to multiple different levels. The area which is behind the thyroid gland or inferior to the thyroid gland, that would be the central neck. But the lateral neck is area lateral to the thyroid gland, which would be this area. And the reason we divide them in different levels, say level 4, level 3, level 5, and level 2, because this helps the physician to communicate with each other. For example, as an endocrinologist, if I see a patient in my clinic, when I do an ultrasound, then I want to tell the surgeon, okay, where did I see that abnormal lymph node? I tell the surgeon, okay, I saw it in level 3. Or I saw it in level 4, or I saw it in level 2. This will help us to communicate with each other. This way the surgeon would know when they are doing the surgery where they should look for that abnormal lymph node. Now, another case. A 21-year-old male with palpable neck mass. He also has no family history of thyroid cancer and no history of radiation exposure to head and neck. He has been also having hoarseness. He comes to our clinic, we do an ultrasound, we found this nodule, which is highly suspicious, and this is another nodule also on the right side. And we also do an ultrasound of the lateral neck, and we find multiple abnormal lymph nodes in the lateral neck. Yes, the first step for every patient with thyroid cancer is ultrasound. But if we find multiple abnormal lymph nodes in the lateral neck in a patient with thyroid cancer, do we need to do any additional imaging? And this is a couple of images of this patient. You can see there are multiple lymph nodes in the lateral neck. And they are all in level 3, level 4, and also, even in level 5, which is not very often that we see level 5. The patient has biopsy, and the biopsy, not surprisingly, of both right and left lateral neck lymph node comes back positive for papillary thyroid cancer. We all need to keep in our mind, thyroid cancer is a surgical disease. That is why we focus a lot on having a good pre-op evaluation. It is very important that surgeon knows about the extent of disease before surgery, because we want the surgeon to be able to remove all the disease as if it is possible during the initial surgery. And so if the patient has multiple lymph nodes in the neck, there's always a concern that there might be some lymph node in the upper part of the chest. There's always a concern there might be a lymph node behind the trachea, that we cannot see those lymph nodes very well with the ultrasound. Those are the patients that we do recommend them to have additional imaging besides ultrasound before they go for surgery. Because if there is any additional lymph node in the area that we cannot see with the ultrasound, we want to know about them before surgery. This way the surgeon can plan the appropriate surgery for the patient, and they can try to remove them during initial surgery. This patient had a CT scan with contrast of the neck and chest before he went for surgery, and not surprisingly, he was found to have multiple positive lymph node in both sides, I mean, on the right and the left. And also, he was found to have lymph node in the central neck, not surprisingly. And that is what the recommendation is from American Heart Association guidelines. A lot of time when I see a patient in the clinic, they ask me, okay, what other imaging do I need to do? Do I need to do any other imaging before I go for surgery? We make that decision based on the extent of disease that we are seeing in the ultrasound. If the patient has extensive cervical lymphadenopathy, which means if the patient has multiple positive lymph nodes, yes, the patient should have a CT scan. And the CT scan needs to be done with the IV contrast because we want to be able to see those lymph nodes. The radioactive iodine is not needed for every single patient with thyroid cancer, but even the one that they need the radioactive iodine, that can wait. It does not have to be done right after surgery. It can be done a month or 2 months after surgery, and that is fine. And that's why the CT scan should not be done without contrast just because we think, okay, this patient is going to need radioactive iodine after surgery. Again, keep in your mind, the thyroid cancer is a surgical disease. That's why it is important that we have a good pre-op imaging. The CT scan should be done with the IV contrast to make sure we can see all those positive lymph nodes and we can remove them in the operating room. And then we can delay the radioactive iodine for a month or 2, and that should be absolutely fine. Another case, a 70-year-old female with no significant past medical history and but comes with a hoarseness. She goes and she sees the ENT, and the ENT do an exam, and they found the patient's vocal cord is paralyzed. And that's why the patient has been having hoarseness. The patient has no family history of thyroid cancer and no history of radiation to head and neck, and she doesn't have any other symptoms. She has no difficulty swallowing, and the only symptoms she has is hoarseness. The patient has a CT scan, the patient is found to have a nodule, and then the patient has an ultrasound. This is a nodule which is highly concerning because it is if this is the thyroid gland, this nodule looks like it is actually invading the thyroid. This is called extrathyroidal extension. Technically, it is invading the tissues outside of the thyroid gland, and that is why the vocal cord is paralyzed, because the vocal cord is invaded by the thyroid cancer. And this is another image of it. This is a trachea. There's almost no normal thyroid tissue between this cancer and the trachea. That's why the nerve is completely out. This is a patient, when I look at the ultrasound, I know this patient has a locally invasive thyroid cancer. This is the patient that I want to know, okay, well, if the nerve is out, is the esophagus also involved? Is the trachea also involved? I'm not a surgeon, but my surgeon would want to know that. The surgeon would want to know, okay, are those structures involved? Are those structures already invaded by the cancer? Because that would be important to know before surgery. This is a patient, again, who needs to have a CT scan with contrast or even MRI to have a better evaluation of a soft tissue before surgery. And so we don't necessarily order CT or MRI on every single patient with thyroid cancer, but these are examples. When there is a concern for locally invasive thyroid cancer, or when there is a concern for possible having lymph node, in patients that have bulky lymph nodes, and there is a concern that there could be lymph node in the upper mediastinum, which is the upper chest, or behind the trachea. Now, we did see our patient, we did the physical exam, we did the ultrasound, we decided if the CT scan or MRI is needed or not. Do we need to order any blood tests? What tests patients should have done before they go for surgery? No questions that everybody should have their thyroid level TSH and free T4 tested. I wanted just to show you exactly, where the parathyroid gland is. As you all know, thyroid gland looks like a butterfly. It sits anterior to the trachea. Behind the thyroid gland, we have 4 small glands that are called parathyroid. The goal is not to remove them during the initial surgery. During the thyroid surgery. However, if the patient has really aggressive type of thyroid cancer and the surgeon has to remove a lot of lymph nodes from the neck, or if there is, for example, tracheal invasion, esophageal invasion, is not uncommon for 1 of 2 of these parathyroid glands to be removed during surgery. And that is where there's always a risk that the patient may have low parathyroid hormone after surgery, which can lead to low calcium. Sometimes the parathyroid gland are not removed in the operating room, but the blood flow to the parathyroid gland can get these parts are going to technically, because there's not enough blood flow to them during the surgery, that's why they may not function really well right after surgery, but they will, function after a few weeks, and the patient may end up on medications for the calcium right after surgery. That is why, as an endocrinologist, even though this is controversial, not necessarily everybody checks a vitamin D. I personally check the calcium and vitamin D on all of my patients before they go for surgery, because if they have a low vitamin D, the risk of low calcium would be even higher. That's why if they have a low vitamin D, always replace that. I always, before surgery, and I always want to have a baseline calcium on every single patient who goes for surgery. And again, not everybody necessarily will have a low calcium after thyroid surgery. We typically see that in patients that they have multiple positive lymph nodes, or in patients that have a really aggressive type of thyroid cancer, but there is always a possibility that patients may end up with a low calcium after surgery. That's why we want to have a baseline calcium before, and we would prefer to replace the vitamin D before surgery if possible. Now, the last thing is, what do our patients think? Until now, we just talk, okay, what would the physician think about what needs to be done from the medical standpoint? But it is also important to know about the patient's preferences, especially in these days, because we are trying to individualize the care of all of the patients with thyroid cancer. In the past, it was a black and white. Everybody was recommended to have their whole thyroid removed, and everybody was recommended to get radioactive iodine. But over the years, we learned that the patients with thyroid cancer, majority of them, they have a really good prognosis. Our management of thyroid cancer has changed over the years. We are being more conservative. We are not recommending everyone to have their whole thyroid removed. Some patients are actually being recommended to just have half of the thyroid removed. And we are not giving radioactive iodine to every single patient, because now we know patients that have a low-risk thyroid cancer, they do well even without radioactive iodine. That is why it's very important that the patient and physician have a very good communications, because now we have options, and we are going to offer options to our patient. And a lot of times we ask the patients, what do they prefer? And that patient-physician communication, now that we are trying to individualize the care of our patients, is extremely important. And one of the discussion that a lot of time we have with the patients that they have a low-risk thyroid cancer in the clinic is the type of the surgery. And because if the patient has a low-risk cancer and we don't expect the patient is not going to need radioactive iodine after surgery, especially if there's no nodule in the other side, and then we offer the patient to get just half of the thyroid removed, which would be partial thyroidectomy. Now, in these cases, because now the patient-physician communication is extremely important, it is also important. It is important for us to know about our patient's preferences, because then that would help us to have a better communication with our patient, and that would help us to actually help them to make that decision. Sometimes if there are 2 or 3 options, it makes it actually more difficult for patients because they don't know what is the best answer for them. And that is why we decided to do a study when I was at Duke University, to learn more about our patients' preferences when they are making a decision between total thyroidectomy and partial thyroidectomy. Because these kind of studies will help us to learn about our patients' preferences, and down the road is going to help us to come up with instrument like a decision aid that can be provided to our patient in the clinic, and hopefully it can help our patients to make a right decision. What we did, we actually looked at all the patients who were more than 18 years old. They were seeing us in the surgery clinic. They were already there for surgical consultation, because we have a multi-PD clinic, endocrine and surgery. They were seeing patients together. It was possible for us to do this study. And we included around 150 patients. We actually created a survey. We did a face-to-face interview with around 8 patients to validate the survey. And after the survey was validated, we used an iPad, and we asked the patients when they were sitting in the waiting room to actually complete the survey. And the survey included risk of low calcium, hypocalcemia means low calcium after surgery, risk of voice change after surgery, risk of requiring to take thyroid medication after surgery, risk of requiring a second surgery, and risk of 5-year cancer recurrence. The way that it worked, technically, the survey was started by telling the patient exactly what is thyroid hormone, what is low calcium, and then we gave patients different scenario and we asked them to choose between those scenario and we tell them which one do you think is your preferred option. And based on that, we learned that when our patients are making a decision between total thyroidectomy and partial thyroidectomy, which means removing half of a thyroid gland, the most important factor which can affect their decision is risk of recurrence. The patient wants to be reassured that even if they have only half of their thyroid removed, they are not putting themselves at increased risk of cancer recurrence. That was the most important factor, which is not surprising. The second most important one was the risk of recurring second surgery. No patients wanted to have two surgeries. They wanted to make sure that if they're having just half of their thyroid removed, they are not putting themselves at a higher risk of recurring to go back for second surgery. And the factors of nerve damage, hoarseness, or for example, low calcium or taking thyroid hormone, they were less important to the patients. The first two important one was the risk of recurrence of the cancer and risk of recurring a second surgery. We also learned that the average patient would favor partial thyroidectomy over total thyroidectomy if we can reassure our patients that the risk of recurring a second surgery is less than 30%. And actually, studies have shown if the patient has a good pre-op workup, the risk of recurring second surgery after partial thyroidectomy could be less than 10%. That is why it's extremely important a good pre-op workup is done before we even have a discussion about partial thyroidectomy versus total thyroidectomy. And we also found that the patients would accept a 4.1% risk of cancer recurrence if the risk of second surgery could be reduced from 40% to 10%, which again, as I mentioned, studies have shown that a good pre-op workup actually can do that. I mean, if the patient has a very good pre-op workup, the risk of recurring second surgery is going to be actually around 10%, is not that high. Now, back to our case. Our patient actually just had a 2 centimeters thyroid nodule. There was no nodule in the contralateral lobe. There was no lymph node in the lateral neck. Then this was a patient that we had a discussion with her about lobectomy versus total thyroidectomy. And after we went over all the risk and benefit of both surgeries, the patient actually chose to have a thyroid lobectomy. And because the patient had a very good pre-op workup, we knew for sure she didn't have any lymph node in the lateral neck. I mean, she was actually found to have a low-risk thyroid cancer after surgery, and she didn't have to go back for a completion thyroidectomy. Now, I'm happy to answer any questions you may have.
Thank you very much, Dr. Ahmadi. I just want to let you know my name is Nancy Santos. I watched your video, your lecture before I had my surgery, and it started a very collaborative treatment, especially going back to the patient. I'm sure a lot of both online and here is happy that we have a say, and we can also discuss whether it's partial or full. Unfortunately, I need to go full thyroidectomy during the surgery. So thank you so much for that information and as a patient. If I have a dysautonomia, pardon my pronunciation of that, and salt helps me a lot with low blood pressure, can non-iodized salt be used? I take bisoprolol for tachycardia. Some nuclear medicine doctors tell me that it can be used and others cannot. I have a lot of Prensicope from the beginning of the diet and had to stay like that for a month. Although I bought Morton non-iodized salt, using it with fear, but if I had not used it, I think I would have fainted.
I'm assuming that Teresa, you are supposed to be on the low iodine diet for radioactive iodine, and that is why you're asking me this question. If you are supposed to be on the low iodine diet, you can use salt that has no iodine. Yes, non-iodinized salt is okay. I mean, we never ask our patient not to have any salt when they are on the low iodine diet. You just need to make sure the salt that you're using doesn't have any iodine in it, but there is no contraindication to use the salt.
I think in some points here, it is very well explained, doctor. Um, I think I could share this with the people here, like pre-operative of the lateral view sonogram is very important, and I think um, we are very fortunate that a lot of doctors, again, are very involved in ThyCa and watch what is the procedure now in terms of the sonogram. So we will check again if there's any further questions in virtual room. All right. Okay.
I can also see the question. Do you want me to read the questions?
Yes, ma'am.
Sure. The question is, I had a partial thyroidectomy because of a benign nodule. 11 years later, I had thyroid cancer in the remaining lobe. How can we say that a partial thyroidectomy was successful until 10 or more years have passed? Can you explain exactly? I mean, I'm assuming the nodule that was found 10 years later was found in the contralateral lobe. And I mean, again, if I'm not answering the question, please let me know. But patients can develop nodule over the years. I mean, and that's what we always tell our patient. I mean, you could have a partial thyroidectomy and it could be very well benign, but then, I mean, 10 years later or 20 years later, you could develop a new nodule in the contralateral lobe, and that nodule could be could be cancer. I mean, having a partial thyroidectomy for a benign nodule is not going to prevent anybody from developing cancer in the contralateral lobe. However, we don't recommend also prophylactic total thyroidectomy just because we may develop a nodule at some point in our life that could be thyroid cancer. I hope I was able to answer your questions.
Yeah, that looks like more of a preventive, having diagnosed, I guess, partial. So probably a recommendation of see the endocrinology every once a year, just to kind of monitor that site.
Yes. So
Uh,
I'm Teresa, and I'm a 50-year thyroid cancer survivor. And so when I was originally diagnosed, they only did the left thyroid, left side of my thyroid, and they said that my tumor was about the size of a tennis ball. And so, which in today's world, that would all, the whole thing would be taken out, I'm sure. Um, but I did have a recurrence, but it was 22 years later on the right side. So I just thought I'd share that. Sometimes it will come back, like you said, but it's a long time and it doesn't always happen. It's just, that was in my case. So, and I'm sure it's because my first tumor was so large is the reason. So I just wanted to share that.
I agree with you. There is always a risk of recurrence. I agree 100% with you. And the reason that it is not recommended for patients with a low-risk cancer to have total thyroidectomy these days is because it has shown that the total thyroidectomy is not necessarily going to change the risk of recurrence. However, do I have patients in the clinic that they have a low-risk cancer and they prefer to have a total thyroidectomy? Yes. And if this is a patient's preference, we do a total thyroidectomy. But we give the patient options. And that is why now these days we are also very interested in learning patients' preferences, and the patient will choose which option they think is the best for them. But no matter what type of the surgery patient has, follow-up is required because there is always a risk of recurrence. I agree with you. I'm taking iodine 100. Okay, I have a CT scan with contrast. To my knowledge, I don't believe you need to go on, to my knowledge, you don't need to stop the iodine for the CT with contrast. We do recommend the iodine to be stopped if you're doing, for example, iodine 123 or iodine 131 uptake on a scan of a thyroid gland. I never ask my patient to stop iodine before CT scan. That's why I don't believe you need that. However, we also don't recommend necessarily patient to take supplemental iodine, especially if they live in the US, because we live in a country that we have, I mean, there is no need to take extra iodine. We have an iodine sufficient country. But I don't believe, I mean, you can double check with the radiology as well, but to my knowledge, I don't think the patient needs to stop the iodine before CT scan. It's usually before nuclear medicine iodine scan that we do recommend the patient not to take extra iodine. I have one nodule that measures 1.3 and the other smaller one with metastasis from papillary and follicular cancer a second surgery is the solution. In May, sorry, I received the iodine, but they said we will wait until December to see the body scan. Sorry, Teresa, I'm guessing you already had partial thyroidectomy and now you have, this is probably the surgical pathology. The patient has a do you mean that you have a 1.3 centimeters papillary thyroid cancer with one lymph node metastasis? Okay, yes, you already had the thyroid removed and you have a 1.3 centimeters papillary thyroid cancer with and the metastasis is the lymph node, or there are two areas of papillary thyroid cancer? Just, okay, the lymph node, got it, okay. If you have a 1.3 centimeters papillary thyroid cancer and there is only one small lymph node, I mean, if the lymph nodes, if there are less than 5 lymph nodes and they're all very small, which means they're less than 0.2, as long as the lateral neck has been already scanned and there is no abnormal lymph node in the lateral neck, as long as you had a good surgery, and also we know that also that there is no nodule in the contralateral lobe that looks suspicious, then your risk of cancer coming back is low. Technically, if there is no suspicious nodule on the other side, if there are no suspicious lymph node in the lateral neck, and there is only one tiny lymph node in the central neck, then the risk of cancer coming back is low, and we do not recommend the patient, based on the current guidelines, to go back for a second surgery. But it's also important to know how many lymph nodes, I mean, what the surgeon saw in the operating room, because it is not uncommon that when the surgeon removes the thyroid gland, one tiny lymph node comes out with the thyroid. But if the surgeon already looked at that area and they did not see any abnormal lymph node and the pre-op imaging also wasn't concerning, then having a one tiny positive lymph node in a patient with a 1.3 centimeters papillary thyroid cancer does not make us too concerned. Yes, we used to get concerned in the past, but the studies have shown that as long as they're all less than 5 lymph nodes and they're all very tiny, the risk of recurrence is still low, and you do not necessarily need to go back for second surgery. That might be the reason that your doctor recommended to wait until December. Regarding the iodine, if you had only half of your thyroid removed, they can't do an iodine scan, because if they give you iodine, all of it is going to go to that remaining of your thyroid gland. If you had the whole thyroid removed, then instead of doing an iodine scan, one thing that we typically do, we do a blood test. We check thyroglobulin, and if the thyroglobulin 4 to 6 weeks after surgery, it's low, then that is already reassuring, and you don't necessarily need to have an iodine scan. I hope I was able to answer your question. Answer? Okay. I had total thyroidectomy in 2002 at Brigham. I live 3 hours from Boston, so have not seen back. I actually practiced at the Brigham. I chose not to have radioactive iodine at that time, but is it too late to consider it? No, if you had total thyroidectomy many, many years ago, and you haven't had a recurrence and your ultrasound has shown no evidence of disease, you don't need any treatment. I mean, it's already 22 years since you were diagnosed and you have done well. And if there has been no evidence of recurrence of your cancer, then you're all good. And thank you so much for having me. I appreciate it. Thank you.
Thank you.